So you're going to benefit from if you have done hundreds of transforaminal discs. Probably that presentation will not be very helpful for you, but if you have done below 100, and if you are about to start or you have just started, that probably will be beneficial for you. I have nothing else to disclose. I practice at the minute presently in Belfast. Belfast is in Northern Ireland, which is on the small island here, as you can see, and this all is part of the United Kingdom, and this is the Republic of Ireland. This is the hospital, how it had been before, and this is the hospital, how it is now. This is the medical university where we teach students. We have amazing anatomical facility that we have already organized courses, and we will continue. Hopefully, I will have you soon. So I'm going to start with a few words about the surgery as a concept. As a concept, surgery is you have to follow the steps of the surgery that will allow you to access a lesion that is inside the body. For this, you have to create a surgical path. So you have to split normal tissues in order to achieve your goals, in order to get the surgical target and to do the surgery. And like that, you inevitably destroy normal tissues. Normally, we try to minimize the trauma of the normal tissues, and this is the basic tenet. This is the aim of the minimal invasive surgery, to minimize the trauma for a patient. So I'm going to give you a simple definition of minimal invasive surgery. That's a procedure that results in less collateral tissue damage, measurable decrease of morbidity, faster functional recovery, and still achieving the goals of the conventional surgery. This is a definition that was given by McAfee in 2010, but I still think this is a valid one. I like to start with that. Minimal invasive surgery principles are to use normal anatomical corridors, which you don't need to cut in order to create. You split muscles instead of cutting muscles. You don't disrupt the muscular tendons and attachments of the muscles. So muscles are very important. As you can see from these anatomical slides, there is multiple layer of muscles around your spine, which are the so-called core muscles, which are very important for the functioning of the spine. And that's why we have to pay the necessary respect to these muscles, and that's why we develop minimal invasive surgery. Why we develop minimal invasive surgery? Why we have to make it complicated? This is a question that many people will ask themselves if they have to start. But there is why, because with the minimal invasive, you will significantly reduce your blood loss and pain levels. You will reduce the need of instrumentations. It's cost effective after you pass the initial stage of developing the surgery. Patients will like it. They ask for it, and it's very popular among the patients. And that will allow you to operate patients that previously you would not consider because of being very obese, have morbidities, high functioning patients as well, which will, the minimal invasive surgery will allow you to operate. There is pitfalls, of course. It's a long learning curve. There is a radiation exposure because you would use a lot of X-ray in order to do different minimal invasive techniques. You need special equipment, and you need to get the proper technique in your hands. Everybody speaks about long learning curve, steep learning curve. That's why I just decided, but I'm not sure if all of us understand what exactly and why the learning curve is steep. That slide demonstrates why the learning curve is steep. So as you can see, initially, the curve goes horizontal, and you achieve your initial experience. but you have to go through all these stages of being novice, being hobbyist, being enthusiast, and finally being expert. So normally you need about 50 cases to achieve a level of initial expertise, but from being from being a relatively unexperienced to become an expert, you need a big number of cases. That's why after the first 50 cases, your expertise will grow a bit slower, and that's why you see the curve is pointed upwards. And that's why we discussed that this is a steep learning curve, because from being a hobbyist to being an expert, you need many more cases than from being a novice to being a hobbyist. So despite the minimal invasive surgery is using different techniques to minimize the access, you have to be aware that despite the minimal invasiveness, that still can give you significant complications. So you have to be considerate about that, and you have to be prepared. So endoscopic discectomies, how to start? Of course, the best way to start a new technique that is complicated is if you can have a fellowship. You can get one of the fellowship programs, but unfortunately they are not available for many of us, or it is too complicated, or you have already well in your practice when you would like to do that, and it's very difficult for you to stop your practice and to be missing from your institution for a long period of time. So let's see if we can have a detour of that, and we can consider different other things, so that can allow us to start endoscopic procedures. Of course, you can attend cadaveric courses. Online courses now are quite popular, and we have a lot of webinars happening at present. You can go on a short-term observerships. You can use online resources, and you have option to get also invited faculty surgeons, which will help you with your first cases. That is now provided by many of the companies which are developing the instrumentations for the instruments for the endoscopic surgeries. So if the problem is very complicated, then one of the best strategies is to crack the problem to simple problems. And I'm gonna give you a few words on each of these points. So you have to consider the anatomy, you have to consider the X-ray acquisition techniques, injections. I have put here steroid injections, which are the pain procedures that hopefully many of us do, and that is something that will help you as well. It is good to have previous experience. You have to be very meticulous with patient selection. You have to be very meticulous with your team selection as well. And also, it's good to have somebody to support you in the beginning. If you go step by step with that, you have a good chance that you will be successful with your first cases. But let's see how and why. So we started with anatomy. Of course, anatomy is crucial to understand if you are starting any new technique. And this is the case with the endoscopic transforaminal discectomies as well. Most of us, during our training, we are familiar, we do a lot of microscopic discectomies, and we are familiar with this zone here, which is close midline and close to the midline. And this is the anatomy that we also are possible to expose if we do interlaminar approach, if we do partial hemilaminectomies, if we do laminectomies. We are possible to expose this zone here, and this is where most of the disc herniations are happening. This is about 1/3 of the disc herniations you will find behind the shoulder of the traversing nerve root. And then you can have also disc herniations which are migrated downwards. You can have disc herniations which are migrated upwards. And you can have the so-called far lateral disc herniations. But with this approach, you can access the majority of the disc herniations. Unfortunately, when we are talking about the endoscopic surgeries, we are from the other side of the facet. And I'm saying unfortunately because this is not a standard training. This is not something that we will be exposed so much during our training, and this is why it is difficult for many of us to start this new technique. So you have to consider that you are not only on the other side of the facet, which is, but also the spine will be oriented differently towards you. The spine is oriented in an oblique fashion, and you have to consider that as well when you are starting a preparation for your endoscopic surgeries and when you're familiarizing yourself with the necessary anatomy. So if we go further, we have to comment on the so-called Cambin's triangle, which is the area that was described by Pervez Cambin nearly 30 years ago now. And this is the working area where you will find your disc herniations and where you will work in. As you can see, with the this diagram is showing exactly the location of the Cambin's triangle with respect of the adjacent structures, the nerve root, the inferior and the superior facet. And this is where is your actual working zone. It's close to the disc and it's close to the inferior end plate. So the lower end plate is your best friend, and let's see why this is the case. This is the case because you are by placing your instruments close to the inferior end plate, you are preventing the neural structures. It's a good diagram that is demonstrating that. As you can see, that if your endoscope is docked closer to the inferior end plates, you have good chance to avoid injury of the exiting nerve root. While if you move your instruments closer to the superior end plate, there is a very high chance that you can dock your instruments on the exiting nerve root and cause neural damage. So again, anatomical considerations are important, and you have to be familiar with this before you start planning your surgeries. Image acquisition is another very important thing that you have to be familiar with, and you have to be possible to tell your radiographer to give you the image that you really need. And there is a few simple rules that you have to follow with doing that. True AP and true lateral image. This is crucial when you're doing endoscopic surgeries, because this will be the prerequisite for your proper orientation. What is true AP image? Ideally, when you are working on a specific level, that level should be in the center of your screen, and you should have the end plate of interest as a straight line, but not as it is demonstrated here as elliptical line. This is if you are meticulous with this, you are having a good chance that you will have good radiological guidance, and that will give you a good chance for successful surgery. So be sure that and make sure that you are acquiring your pictures properly, and make sure that the end plate of interest is a straight line. Another simple rule that you have to follow for a true AP image is that you have to make sure that all the times and with all the pictures, the spinous process is right in the middle between the two pedicles. If you follow these two simple rules, then there is a good chance that your AP will be true AP, and you will have the right guidance. Similar principles when you are when you're getting your lateral images. You see that the true lateral image means that your end plate of interest should be presented as a straight line, but not as elliptical line as demonstrated on the right hand side. So as you have to have constant 3D orientation, you have to constantly switch between AP and lateral orientation of your image intensifier, and acquisition of good X-rays is of paramount importance for successful completion of your case and for avoiding complications. So that is demonstrated by the following few slides that I'm gonna show you. As the first step of the endoscopic transforaminal surgery is proper docking of your working cannula. The 3D awareness is of paramount importance, and I will show you now why. As you know, if you have attended different courses, you've been taught that the offset of the starting point of your instrument varies as you go up from L5S1 towards the upper lower levels. You can see that this is demonstrated on this slide. You see that at L23, you start from 7 to 9 centimeters offset from the midline. And at L5S1, you can go as lateral as 16 centimeters. This is a good guidance when you're starting your endoscopic surgeries, but with experience and with cases that you will do, you will see that you automatically gauge the line, the distance, and you are not measuring as meticulous as you were doing that in the first cases that you were planning. These are two important lines that you can. I don't measure the offset of the midline in my cases, but I normally aim to be between these two lines. This is the line that connects the top of the process, the line that will connect the top of the facets. If you're between these two lines, you have a very good chance to be following the right trajectory, have success of your surgery and to avoid complications. So regarding the biplanar 3D awareness, what I mentioned to you is that you have to be constantly aware on AP and lateral where it's of your event, and this is demonstrated by these few slides that I have just projected to you. And this is the starting point. Irrespective of the step will be docking of your instrument or needle at the tip of the superior articulating process. And that's demonstrated on the right hand side of that slide. And on the left hand side, you have to see that you are just entering ideally just entering or just before entering the foramen. However, If you progress and if you see this picture on AP, that is a good AP picture, but if that is your lateral projection, this is obviously something that should concern you. That is the importance of 3D biplanar awareness, because if you project your trajectory based on the X-rays which you have just seen, that could be a possible trajectory that your instruments are following. And that's obviously something that you don't want. You don't want to have injury of the internal organs. So trajectory is very important, and your 3D awareness is very important for proper docking of your instruments and for avoidance of complications and for performing your surgery. Steroid injections, I have mentioned to you before that the steroid injections are possible to help you with the start of this procedure, if that is something new for you. Before I started my first cases, I have done probably over 100 transforaminal injections following the trajectory of the endoscopic disc surgery, transforaminal disc surgery. And this will be very, very helpful, because like that you are possible to train the trajectory and proper starting point on the skin of the patient, and proper docking of the instrument is a very important first step that will make your surgery later on easier, and respectively very difficult if this is not right. Another benefit from that will be that you will have a good experience, and you will be faster with docking your instrument on the right spot. And this will help you with shortening your intraoperative time. First of the cases that you normally would start doing will be under a local anesthesia, because that is the technique that will give you feedback. And despite of the good anesthetists that you will have, and the anesthetists that will give you good pseudoanalgesia, you still have to be fast enough, because this is docking is a relatively painful procedure. And if you start poking to find the superior articulating facet while the patient is just sedated under local anesthesia, that might give you problems, and the patient may start moving, and you lose your images, and then the surgery can fail very easily. So I strongly recommend you, before you start doing your planning your first patients, try to do steroid injections following the trajectory that you will normally follow for your transforaminal endoscopic surgeries. That will definitely help you. Previous experience definitely will help. If you have endoscopic experience before you start planning your first surgeries, that is something that will be beneficial, definitely. Also, if you have previous experience in the area where you will be doing your endoscopic surgeries, like if you have done before some work in the Camden's triangle, that will be something that also will help you a lot. Before I started my first endoscopic cases, I already had significant experience, and I had probably over 200 cases done minimal invasive transforaminal surgery, and this was something that was very beneficial for me. Supporting team is very important. If you are starting a new technique, you definitely need a good scrub team that is aware of the instruments and it's aware of the routine, and you don't need to divide your attention to tell them what to do. Anesthetist is very important as well, because, as I said, your first cases will be under pseudoanalgesia, and if you have experienced anesthetists that can give you a good sedation, and good pseudoanalgesia that will be very helpful for the initial cases, which will be inevitably slower and more difficult. Radiographers are also very important. If you are planning to develop this surgery, you probably have to consider working with one and the same radiographer, because the X-ray acquisition is very important, and as I have demonstrated earlier to you, good X-rays and true AP and true lateral that are acquired fast is going to be very important for you. But if your radiographer is new with this technique, and he needs to take many pictures before he gives you the right picture, that will add quite significant amount of intraoperative time. Also, that will give you significant radiation exposure, which is unnecessary. Faculty surgeon is something that you have to consider for your first cases, in case you have not gone to a fellowship and you're not confident with the new technique. Faculty surgeon is now provided by most of the major companies which are developing this instrumentation. So patient selection, what should be the first patient, or the first 20-30 patients that you will consider to operate with this new technique, in case you are just starting. So ideally, this should be a young, fit and slim patient. Ideally, you have to select for your first cases L4, L5, a large extruded disc, which ideally should be paramedian or recessive disc. You should consider a case which has not so much degeneration, and that will give you good foramen width, and that will allow you to place your instruments and still not injuring the exiting nerve root. You have to consider anatomical variations. Sometimes you can see iliac crest quite high, especially with the male individuals, male patients. So you have to be sure that the iliac crest is also not on your way. This is despite L4, L5 regions, sometimes iliac crest can be also very difficult to overcome. So a few words about the possible complications. You can expect to have more complications in the beginning, but you have to make sure that the complications are not major, and this is not because if you have a major complication in the very beginning, that is likely to put you off and to stop developing that surgery. So vascular complications are one of the most significant complications that you can have with the disc surgery. Obviously, with the open surgery, we know that despite it is happening very, very rarely, about 4 to 5 over 100,000 surgeries. This could be devastating, and you can lose your patient. With endoscopic disc surgery, you can almost zero this percentage, and this is something that's one of the reasons why you would consider. There is a few reports though still, but they are only single reports. There is not much reported with respect to vascular injury. There is one report from '89 on sigmoid artery injury. If there is a left iliac vein injury from Kim on 2010, but if you research the literature, there are not many, so this is reassuring. What is prevention of the vascular surgery? Generally, vascular injury. Generally, if your entry point is too medial, and and then you have chance to your instruments to slide forward and to have vascular injury. That's why you always have to check the position of your needle on lateral and AP image, as I have demonstrated before. You have to consider these two lines. If you're below that red line, you have a very high chance that your trajectory is is not right, and you have to correct it. You have to consider also that you may have peritoneal and abdominal injury. Still not many. If you go and see the literature, there is single reports on ureter damage, bowel necrosis. You can have colon perforation and psoas abscess, but still we don't see so many of these even in the large series. This is a picture demonstrating psoas abscess from Escherichia coli, not my complication, luckily. Neural injury, the incidence of open surgery and endoscopic surgery, neural injury is more or less similar. However, it is likely when you start having your surgeries, you can your initial cases, you may have more neural damage, and usually this will be dysesthesia because of irritation of the dorsal root entry of the ganglion. Sorry. So dural injury, again, with the endoscopic surgeries, you can expect less dural injury comparing with the open surgery, but it is not zero, and especially with your first cases, and as you're familiarizing yourself with the technique and with the instruments, you may have a dural injury. The good thing is that even if you have a small dural tear, you can just leave it as it is, and the consequences are minimal, or it will be completely clinically silent. In my initial series, I had small dural tears, and I don't remember needing to go and repair this dural injury. So endoscopic surgery is again favorable with that. Infection, again, anecdotal reports for infection, as I have showed you before. So if you follow the sterility rules, if you're very careful with the use of the C-arm, and if you're considerate about your 3D location, then you can avoid infection injury. If you see your needle accidentally going too anterior, you may be retroperitoneal or even peritoneal, and you may consider changing your needle, and that is good prophylaxis. I mentioned already about the dysesthesis because of the irritation of the ganglion. It's almost always temporal. You may consider temporary. You may consider using steroids to decrease incidence of dysesthesia of your early patients. Instrument fracture is also something that you may have, especially with your initial cases, and this is happening because you're normally very aggressive in the beginning, and you're not familiar with the technique and with the instruments. You have to try to avoid that as well, because this will be bad complications. Residues and large fragments left behind. This is also something that can happen. And in some of the early series, if you check the literature, the reports say up to 1/3 of the patients will have residual and retained disc. Don't jump for early post-operative repeat surgery, because if you leave the patient for a couple of months, the residual may disappear on the follow-up scans. So in case your patient is not symptomatic in the beginning, you may consider watching them in case you leave residual disc. And that was it. Thank you so much.